Hi everybody, my name is Sophia Delaviori. I'm with the Reproductive Health Supplies Coalition. Thank you so much for joining us today. So I think we'll go ahead and get started. We have a number of people online and it's a little after 10. So just in case you're not familiar, I'll give a brief overview. The Reproductive Health Supplies Coalition is a membership organization with over 370 partners committed to increasing access to a full range of affordable, quality reproductive health supplies in low and middle income countries. And through the Reproductive Health Supplies Coalition, we have a small grants mechanism known as the Innovation Fund, which is our flagship initiative for high impact change. And this is our mechanism for financing innovative ideas to increase access to reproductive health supplies. So we're really excited about this project, which has been really exciting for me to follow along with. And we're incredibly grateful to the whole ICRH team, and especially Helene, for all of their work. So with that, Helene, I'll turn it over to you.
Thank you very much, Sophia. So welcome everyone to this presentation. So I'll start right away with presenting the results of our project, Enhancing Motivation of Family Planning Services Providers as a Lever to Avoid Stockouts and Increase Quality of Services. So I would like to start with presenting a simplified situation of a stockout. So if a stockout occurs in a health center, it can be caused by a stockout at higher levels, of course. So if the warehouse doesn't have any type of contraceptives, and even though the health center has ordered it, they won't get the delivery, so they will have a stockout. Now, secondly, also structural problems may cause stockouts. For example, if in the rain seasons the roads are in bad conditions, health facilities can become inaccessible, so deliveries won't get to the health facility, so again there can be a stockout. And finally, there can also be personal factors, problems at a personal level. And when I think about problems at personal level, I think about personal motivation. Are healthcare providers always motivated to monitor their supply? Does low motivation lead to stockouts? So we wanted to set up a project to investigate that link between personal motivation and stockouts. And so we wanted to design an intervention that would increase motivation and decrease stockouts. As such, we would be able to investigate the link between motivation and stockouts. So what were the research activities that we set up? So here's an overview of our activities, and I'll take you through it step by step. Let's start with the blue arrow. This is representing the 10 monthly facility audits assessing supply management. So we had 15 health centers in our project, and each of these health centers was visited once a month by our field workers. And the field workers carried out 3 main tasks during each of these visits. They took pictures of stockouts of 6 family planning methods, namely the female condom, IUD, implant, microlip, microvaginal, and depot. So they took pictures of these stockouts. They also counted the actual stock of these 6 family planning methods, and they also took pictures of the overviews of patient registers so that we would have an idea about usage and of the family planning services in each of these health centers. Now this information, and more particularly the stock cards, were immediately evaluated and results were reported back to the health centers assigned in Group 1 and Group 2. So Group 1 and Group 2 got monthly feedback, so at Group Month 2 they got the results of Month 1, Month 3 they got the results of Month 2, and so on. But what do I mean with results? Well, we set up a system through which health centers could earn credits, and every month the health centers in Group 1 and Group 2 would receive this report of the credits. Now the credit system worked as follows. Given that we asked them to show us the stock card of 6 family planning methods, we gave them 1 credit each time, each month, they could show us all of these 6 stock cards. They could earn another credit if in none of these stock cards a calculation error occurred. So if there were all zeros here, they would have had a credit. But in this example, for example, a calculation error occurred in the stockart of depot, so they lost their chance to earn a credit, so they have 0 credits here. Similarly, we also wanted them, or we didn't want to see stockouts, so if in none of the stockouts they reported, a stockout, they could earn a credit. Now in this example, given that they had a calculation error in the stockart of depot, we figured that we couldn't rely on that information anymore, so this became a missing, so they didn't earn a credit for their stockouts. So these health centers in group 1 and 2 could earn 0 up to 3 credits each month, and this was what they got every month as a result of their supply management and of the evaluation we made of it. Now, for the analysis, we used another system that was a little less punitive, because if you have a calculation mistake, you immediately lose the chance to have a credit for stockouts. And also, if they weren't able to show one stockart, they lost the chance to have a credit for calculation error of stockouts, because we could simply not evaluate all stockarts. So this was very punitive, because we wanted them to push to really have these stockarts, because this is the start of good supply monitoring. But in terms of analysis, we used another system that I will shortly explain here as well, so that you can later on understand the results I will show. So we were less punitive. So in the point system, they could have a point for each stockart they showed, so 6 for each in total. Then they could have a point for each stockart without a calculation mistake. So again, the maximum was 6 in this example. They got 5 because of the error here. And then they could earn a point for each stockart without a stockout. So the maximum was 6, and here they got 5 because here we missed information. So we evaluated them and analyzed results based with 18 points they could earn each month, while they got the simplified version, and they got the results of the credits from 0 to 3 credits a month. So group 1 and group 2 got these reports every month, but for group 2 these credits were a bit more important, given that they were linked with incentives. So each time they earned credits, they could change them for material goods, such as small furniture or little medical equipment to use in the health facility. So this should, in theory, motivate them a bit more to make sure they have good supply management. Then also the health centers in group 1 and group 2 got a motivational training in between months 6 and 7. And just to be clear, group 3, this is our control group. These health centers did not receive any of these interventions, but they were visited each month so that we could collect the same type of information in order to compare these centers with the centers in group 1 and group 2. Now, besides that, we also collected data regarding motivation, because of course we wanted to see if these interventions would, 1, decrease stockouts, and 2, increase motivation. So we measured motivation, and we measured motivation among healthcare providers of our health centers 3 times, at baseline, then a first follow-up, and a second follow-up. Now, how did we measure motivation? Well, we conducted face-to-face interviews among the providers of all the health centers in our project, and to do so we used a questionnaire, a scale developed by Mutali and al., which included 21 questions, each answered on a scale of 1 to 5. So 21 questions on a scale of 1 to 5 made that the maximum score of motivation was 105. Now this scale has 7 subcomponents. It addresses conscientiousness, intrinsic motivation, organizational commitment, burnout, timeliness and attendance, job satisfaction, and general motivation. So for example, participants were asked, do you feel motivated to work hard? 1, I strongly disagree. 5, I strongly agree. They were asked, overall, are you satisfied with your job? Are you proud to work for this health facility? Do you consider yourself a hard worker? And so on. So with 21 questions of this type, we evaluated their motivation 3 times. And then finally, we also organized focus group discussions with healthcare providers. We did this twice, once as a mid-evaluation and then a final evaluation to have their perspectives of the project and how they perceived the interventions, and if they thought their motivation has changed, that they see a change in supply monitoring, and so on and so on. So these were the activities that we carried out. So where did we do that? Well, we did that in Mozambique, in the province of Maputo in the south of Mozambique, and we carried it out in 2 districts in Maputo Province, in Marapenye and in Manisa, both more or less close to the capital, so 30 kilometers and 80 kilometers respectively. Now there were 15 health centers included in our study, and so given that we had 3 groups, there were 5 health centers randomly assigned in each of these groups, and they were all type 1 health centers, which means that they are the smallest type of health facility in Mozambique. They offer basic health services and so also family planning services. Now let's talk about the results. So I'm first going to describe a bit the family planning services offered in these health centers to have an idea about which type of health centers we're looking at. So these are the 15 health centers, and these are the number of consultations during the 16 months before intervention. So we had information of 2014 and so on. And this is the median number of consultations per month in each of these health centers. And we see a huge variation. For example, in Maraga, they have over 400 consultations a month. In Matalane, even less than 50. So this is the first thing we need to take into consideration. We have big health centers, we have small health centers, as normal. Now, what type of family planning services are offered? The red bars now present the consultation where pills are prescribed. So we can more or less say that roughly during half of the presentation, of the consultations, a pill is prescribed. And I can also tell you that the figure for depot looks pretty much the same. So the pill and depot kind of form the total of consultations in these health centers. They're the main family planning methods used in these health centers. So it shouldn't come as a surprise that, for example, IUD is not that much offered. This is here the sum of IUDs inserted by each of the 15 health centers in our project during the 16 months before our intervention, so for 2014 on. We see that there are some centers who simply haven't inserted IUDs, and then some centers that have inserted almost 50 or 50 IUDs. It's still not much, but it shows again the variation in these health centers. Some offer IUDs and some don't. And then finally, regarding the family services, I would like to show this figure. These are the number of consultations during 26 months, so from January 2014 on to the end of our project, February 2016. And this is we give here the number of first consultations, so new patients in each of our 15 health centers. And we see clear peaks every 6 months in most of the health centers. And in some of these health centers, the peaks are very pronounced, and some the peaks are hardly there. So the peaks represent national health weeks in Mozambique, during which in some regions 30 up to 50% of family planning services of the year are offered. So these are really booms in demand. It's really the number of patients just rises during that month or week more specifically. But again, we see variation in health centers because there are health centers who hardly participate in these health weeks, and there are health centers who do. So I think the point is here that we have a whole variation of health centers in our study. Then the baseline results of motivation. So we measured motivation with our questionnaire, and we measured this among 55 healthcare providers in these 15 health centers of our project. And let's start with looking at this figure, and we see that if we calculate the score of each of the subcomponents of our scale, that is always very high. It's a minimum of, the median score is minimum 3.5, and it's very often 4 and even 5. So overall, the healthcare providers reported a very high motivation at baseline for all of these subcomponents. And if we look at the median score per group, we found that group 1 had 93, group 2 85, and group 2 had 87 out of 105. So all three groups had very high motivation, and this wasn't significantly different. So they started at the same foot, let's say. They were comparable in terms of motivation, our three groups. However, when we break this down at a personal level, it becomes a bit more difficult or complex. In this figure, every dot is a person, and here we see the 2 employees of Health Center 1, of Health Center 2, the 4 employees of Health Center 3, and so on. And this is again, the y-axis shows the total motivation measured at baseline. So here you see that we have health centers where, for example, there are 3 highly motivated employees with 1 much less motivated. Or here, the spread among in motivation among the employees is quite big. Here, they're all very high. So when we break it down at a personal level, we do see some variation. While if we look at averages of median scores, this is, the red line is representing the average of each of these centers, with a few exceptions of some outliers, the average score is more or less the same, while in reality there is quite some variation in each of these health centers. So this is important to remember. Then what about supply management? How did the health facilities during the first field visit? So remember, we asked them to show 6 stock cards, so of 6 family planning methods, and this is the results are presented here in the blue bars for group 1, group 2, and group 3. So at baseline, group 3 could show us 70% of the stock cards asked for. So given that there were 5 health centers in each group and we asked 6 family planning method stock cards, means that they could show us 30 stock cards, and in group 3 we got 70%, so 21 out of 30 stock cards. Here we got 90%, and here we got 83%. This was not statistically different, so again, not that much variation. But if we would look at the health centers separately, there were some health centers that could only show 2 out of the 6 stock cards, while there were also health centers who could show us 6 stock cards. So again, the variation was present, but when you take, when you group results, when you take averages and median scores, then you lose a bit of that variation. What about the calculation errors, the second type of evaluation we made? Well, we saw that among the stock cards that the groups could show us, in group 1 there were 67% of the stock cards with calculation mistakes, here 65 in group 2 and 77 in group 3. So there were quite a lot of calculation mistakes made, but again, there was quite some variation in the health centers. There were health centers that showed no calculation mistakes, and there were health centers with 60% calculation mistakes. Now, regarding the stockouts reported on the stock cards, so in group 1 we had 57% of the stock cards that they could show with a reported stockout. Here 47 and here 55. And again, the variation in the health centers was quite big. There were health centers where they had none stockouts reported in the stockouts, and there were health centers with up to 60% of the stock cards reporting a stockout. So to wrap up our baseline results, we find high motivation among the employees, but there is high interpersonal variation. we find poor supply management. Roughly 50% of the features the stock, so the stock cards that they could show had calculation errors and reported stockouts. And we also saw quite some variation in usage among these health centers. Some had high number of patients, some low, some offer IUDs, some don't, and some really participate in these health weeks in Mozambique, and so we saw the cycle of 6 months in demand. Now, what about the results of the intervention? Did we see any change in motivation? Well, here we see the median score per group for the motivation, and so at baseline, at first follow-up, and second follow-up. And I think it's clear that we don't see much of a change in none of the groups when we look at the median score. It remains very high, always above 80 out of the 105 points they could get. Now, however, looking again at it at a personal level, now here we're not looking at the median score, we're looking at the difference in motivation. So what we did, we took the score that they had at the second follow-up and minus the score at baseline. So basically, if you're above 0, your motivation increased. If you're below 0, your motivation decreased. And so we see that there are health centers where somebody has a decreased motivation and where others have an increased motivation. There are also health centers, for example, number 5, where they more or less stay the same or decrease, and there are health centers where they both increase. So while on average and with the median scores we don't see differences, we do see differences at a personal level. And of course, motivation is something that can differ from day to day. So this is also, it is logic to see variation when you measure motivation more than once. Now, quantitatively, we couldn't really find results or any trends in changes of motivation. But in the focus group discussion, the project was always described as motivating. For example, one participant said, "The project motivated us to always update the stock cards, so one way or another it improved our services, both of the nurse and the pharmacy. Yes, our services improved." So they felt that it was motivating. They felt that it improved their services. Regarding supply management, what did we see? Remember the evaluation system that we set up and that they could earn credits, and that we also used the system of points to evaluate them. So they could earn 6 points each month for showing 6 stock cards. They could earn 6 points for having stockouts without calculation mistakes, and they could earn 6 points for having stockouts with no reported stockouts. So in total they could have 18 points each health center, given that there are 5 health centers in each group. Means that the maximum number of points that a group could earn was 90. And we see in group 1 how they increase, and they get close to 90 with a little drop, and here they get the maximum and they stay more or less high. We also see in group 2 improvement with some drops in month 4 and 8, but they have several months where they get the maximum score. So that means 6 features the stock, 6 stock cards without any calculation mistake and without reporting stockouts. Group 3 also increases, but more slowly. So they only get once the maximum score, and they lag a bit behind compared with group 1 and group 2. So it's nice to see that even though the points in group 1, so the results they got back always, the feedback, that they were not linked with incentives, it did increase their motivation. And for example, a participant in the focus group discussion said, "When you started visiting our clinic, we learned how to fill in stock cards and we became motivated to use them and to win the credits. This made us realize that we're pleased with the work we're doing, it's a beautiful job." So the points, the credit system was very much appreciated, and it made them proud and happy about their work and the fact that we recognized that work, of course. Now remember, the points are a combination of having stock outs, not having calculation mistakes, and not having stock outs. So let's see the first component, the number of stock outs they could show. We asked 6 stock outs each month among 5 health centers in each group, so here the maximum was 30. And we see more or less the same trend as we saw in the previous chart. We see how it increases and how by the end they almost get the maximum. Also in group 2 with a bit of a drop in month 4 and month 8, and also we see how the group 3 is increasing but at a slower pace. Now it's quite impressive that just by visiting these centers, because in group 3 there wasn't any feedback, there weren't incentives to win, so just by having these monthly visits they had more features of stock, they had more stock cards by the end of the project. And in a focus group they said, for example, I did not have a stock card of female condoms, but the visits helped me realize that I need a stock card and that even if I don't have stock, I need to fill in the stock card. So just by asking stock cards month after month, the healthcare providers felt motivated to get the stock card and to start monitoring their stock. Now, what about the calculation mistakes? Did we see an improvement? Did we see less calculation mistakes by the end of the project? Now, this is a bit tricky to evaluate because what do we need to do if they didn't show the stock card? If we miss a stock card, we can't, of course, say whether there was a calculation mistake or not. So we can assume that we can evaluate them in a nice way, and we can assume that if they would have had a stock card, they wouldn't have made a calculation mistake. We can also evaluate them in a very strict way and say, well, if you don't show me the stock card, I will assume that you would have made a calculation mistake if you would have the stock card. So this figure shows us the first version. Let's assume that if they don't show us a stock card, that they don't have a calculation mistake. And we see that in group 1 there are hardly any calculation mistakes, and by the end of the program they don't make calculation mistakes anymore. In group 2 the results are even more impressive, no calculation mistakes after 1 month. And group 3 they also improve, but it takes them again a bit more longer, but by the end they also don't have calculation mistakes. If we make the evaluation more strict, and if we say that if you don't have a stock card, then I will assume that if you would have had one, you would have made a calculation mistake, then we get, of course, more calculation mistakes, but the trends stay more or less the same. So, meaning that group 1 we see an improvement, group 2 even a better improvement, and group 3 an improvement, but at a slower pace. And for example, in group 2, they said, in my clinic I can say that the incentives are helping a lot. All my colleagues came to talk to me already. Nurse, have you filled in the stock cards? Even when I'm busy, they always remind me. My assistant, for example, already handles the stock cards and says, nurse, please sign, so the incentives are helping. So here the people of group 2, the incentives group, really showed that they appreciated the incentives and that the project made the supply management as a responsibility of all. They were all concerned about the stock cards. And then finally, the stock outs. Did we see less stock outs reported on the stock cards? Well, again, we can make the same evaluation as with the stock, as with the calculation errors. If we don't have a stock card, we can assume that there was a stock out. Or if we don't have a stock card, we can assume that they didn't have a stock out. Sorry. So here, this figure shows us the evaluation, assuming that if they didn't have a stock card, they did not have a stock out, so that it doesn't mean that they have a stock out. And we see with similar results as with the calculation errors, an improvement in group 1, an improvement in group 2, even better, and group 3 lagging behind. If we evaluate them more strict and we assume that no stock card means that you have a stock out, then we see again yeah, that there's definitely room for improvement. They still have quite some stockouts, but there is improvement. The project does induce improvement, also in Group 3. And for example, a participant of Group 1 said, before the project, I had frequent stockouts of contraceptives and I did not understand why. But now I think it is lack of communication between the pharmacy and the nurse. Because of the project, we no longer have stockouts of both contraceptives and other drugs. It improved the way of working. So while we did still see stockouts, there is an improvement, and here the participant even reflects about causes of stockouts, and they have identified that communication is really key to prevent stockouts. Now, if you remember from the beginning of the presentation, besides taking the pictures of these stockouts and evaluating the stockouts, we also actually counted stockouts. So this is another way of measuring stockouts, and it also resulted in other results. This is a representation of the sum of the stockouts during the 10 months of each of the groups. And since that we evaluated 6 family planning methods, they could have a maximum, and there are 5 health centers in each group. The maximum of stockouts each month would be 30, and luckily we're far from 30, but we do see still a lot of stockouts on the day of the assessment. We see that it's better in Group 2. Group 1 is also better off, but in Group 3 there's definitely room for improvement. Now, if we look at these stockouts, we can ask ourselves 2 things. Are these stockouts caused by stockouts of a particular method? Is one method causing more stockouts or leading to more stockouts than another? And also, are there certain health centers contributing more to all of these stockouts than other health centers? So let's start with having a look at the first approach. So which of the family planning methods is leading or is having the most stockouts? So here we have the percentage of stocked out health centers over 10 months. And it's clear that female condom, IUD and implant, they have clearly more stockouts, definitely in our control group, compared to Depot, Maputo and Microgenon. If you remember from the results I presented about the usage of family planning methods in these health centers, Microgenon, Maputo and Depot were by far the most used, the most asked family planning methods. So it's a bit contradictory. You would maybe expect that methods that are used more have more stockouts, but maybe a hypothesis in this situation can be that if they're used a lot, then healthcare providers make sure that they always have them. If demand is lower, like for IUDs, implants and female condoms, healthcare providers tend to forget about them and they run out of stock at certain moments. Now, what about looking at it at a level of a health center? Are there health centers that have more stockouts than others? And we actually identified 3 types of health centers, 3 types of stockouts during these 10 months. The first one here is an example of Ricatla Health Center, and we see very few stockouts, just almost sporadically they have a stockout. Maybe this is caused by a stockout at a higher level, but the problem of stockouts is really not that big in Ricatla. A second type of health center or stockouts that we find were kind of peaks of stockouts. So a certain period of time, they had 1 or more stockouts. And so you could start wondering whether this can be linked with, for example, a national health week, where the demand suddenly increases and they can't keep up with stock supply. Or maybe this is linked with rain season, and so the roads were in bad conditions, and so the supply doesn't get to the health facility. So it's definitely different from the ones where we hardly see any stockouts, and here we see this peak of stockouts. And then finally, a third type of centers with a third type of stockouts, let's say, or pattern of stockouts, are those centers which have continuously stockouts, and centers where we see more than 1 stockout also. So here it might be more a structural problem. Maybe they never offer female condoms, so they basically always have a stock out of a female condom. So it would be interesting to investigate a bit more about what the reasons are behind this type of patterns of stockouts. So to wrap up a bit the results I just presented, we saw a change in motivation, not really when we look at averages or medians among the groups or among health centers, but intrapersonal there is variation in motivation, so we might need bigger sample sizes to really see changes in motivations linked with interventions. We also saw an improvement in supply management. All health centers, even in the control group, had more stock outs by the end of the program, had less calculation errors and reported less stock outs. But we also saw that when we look at the stock outs of the day of the assessment, we still see that there are stock outs, and we have quite some variation among health centers and among the methods. Now, there were also some barriers that made it difficult for us to implement the project or barriers that interfered with the results of our project. For example, during the focus group discussion and the field visits, we noticed that there is definitely a lack of staff in all of these health centers, and so that they have a very high workload. So it's difficult for these healthcare providers to really respond to a project or respond to an evaluation system when they're so busy with their day-to-day work. We also saw that there's a high staff turnover, and this makes it this makes it difficult to see really trends in a certain health centers in terms of services of motivation, because the staff is always changing. Or, for example, if you remember from the very beginning of the presentation, we also organized motivational training for the health centers in Group 1 and Group 2. Now, they were positively evaluated by the participants, but it was very difficult to get more than one participant of certain health centers. So if we wanted to work during that motivational training about group work and communication between healthcare providers, then of course if only one member of a health center is present, then it becomes difficult. So the high staff turnover definitely also interfered a bit with our project. And then finally, the situation where the healthcare providers work in the poor infrastructure, the poor environment, also makes it difficult. For example, there was one health center that during rain season they had leakages in the roof, and they simply couldn't show any of their stock cards because they were all destroyed by rain. So you need to take this into account, and of course this influences both the implementation and the results of our project. Now, conclusions and recommendations. In terms of interventions that lead to higher motivation and a decrease in stock out, I think our interventions were successful because we see improvement among the three groups. And this is partly due to those regular visits and feedback that the health centers received. So it showed how important their work is, that somebody comes month after month to monitor and to give supportive feedback on their work. Also, the incentives were important. In Group 2, during the focus group discussion, it became clear that they did care about these incentives. And finally, overall, it's the recognition for their work that increases their job satisfaction and motivation, that shows that their work is really important. For future steps, well, as I said before, since we detected these certain patterns in stockouts in different health facilities, we believe it would be very valuable to further explore characteristics and reasons behind stockouts and the patterns of these stockouts we detected. So to see whether or not motivation of providers can be linked with certain pattern, or whether the relation of motivation and stockouts is influenced by certain characteristics of health facilities. So as a way of exploring already this a bit, we started investigating certain trends and characteristics or events that may influence stockouts with the data that we have gathered at the moment. And I will give you just one example to show you, to give you an idea. So for example, here we have the availability of the pill microlute in a health center reported by the nurse on her stock cards. And you see how the stock is decreasing. So at a certain point she has over 200, and it decreases as patients are coming. And she's actually reporting very well. She gives us a lot of data. So she fills in her stock card regularly. We also see that there are quite some gaps. At certain points she doesn't fill in her stock card anymore. And when we look at the usage of this health center, we see that she doesn't fill in her stock card when the demand is so incredibly high, and this is in these weeks of the National Health Weeks in Mozambique. So probably she's too busy with offering health family planning services that she can't fill in her stock card anymore. But this is actually also, but there's also a gap here that is not linked with such a high demand. So here there must be other reasons why suddenly she doesn't fill in her stock card anymore. Now here this center is quite clear in terms of trends, and we don't see any stock out, so it's very good. But to give you an idea about the data, this is another health center giving us the availability of the pill microlute in another health center, as I said. And so here the trends are not that clear. We see stockouts during high demand. So it's very difficult, and that's why I also started this presentation with showing all this variation in health centers in terms of usage, in terms of what they offer, demand, and so on. So it's very difficult to look at these trends, but we believe it can be very interesting and give very valuable information in how stock cards occur and how we can prevent them in the future. So with this I end my presentation, and I would like to thank first of all the participants of our projects, all the healthcare providers that participated in the project. I would also would like to thank the International Center for Reproductive Health in Mozambique. Our colleagues in Mozambique did all the field work and collected all the data, so thank you very much for all the effort. And I would also like to thank, of course, the Reproductive Health Supplies Coalition for giving us the opportunity to implement this, this project. So now, if there are any questions, I'm happy to answer them.
Thanks so much, Helene. That was an excellent presentation. For everybody who's joining us, you're welcome to chat in your questions because we have everybody on mute to prevent feedback and echoes, but you'll see that on the toolbar you should have the capacity to send in questions, and we can read those aloud. We'll give you just a moment if you have any questions. So we have one question from Justice wondering how you determined your sample size, Helene.
Yes, so we started this project with the idea that we would implement it in the two districts, Maracuene and Manisa. These were basically chosen more on practical considerations, so we needed to have districts that we could visit every month, so we needed them to be a bit accessible. And then in these two districts there are 21 health facilities of type 1, but we had to exclude 6 based on 2 problems that arise. First of all, there were 2 or 3, I don't remember exactly, health facilities that did not offer family planning methods, so these were excluded immediately. And then there were also, I think, 4 health facilities that were less accessible, so it was really difficult to visit them each month, and we realized that this obviously has an influence on stockout, because if we can't reach them every month, then how can the supply reach these health facilities? But we had to exclude them because it was simply not possible, not feasible to visit them each month. So yeah, we ended up with the 15 health centers in Maracuña and Manisa that were more accessible to us. I hope that answers the question. Now, and maybe I can add to that then the number of healthcare providers that we interviewed, we did end up with a smaller sample size than originally planned. We thought that we would be able to interview 5 healthcare providers per center, so maybe 7 at 1 at the bigger centers and 3 at the smaller centers. But it turned out to be very challenging to interview them, so they had to make time for us, of course. And also in the follow-up rounds, so we started with 55 healthcare providers, but we ended up with only 39. So due to staff turnover and so on, it's very hard to keep the participants in your study. We realize it's a small sample size, and that's where quantitatively it's very hard to evaluate this project, but I think there are many trends that point in the direction of that it did increase motivation, and it did help in better supply management, and also the focus group discussions definitely confirmed this. But to analyze this project quantitatively was quite challenging indeed, because of the quite small sample size.
Thanks, Helene. We have another couple questions. One from Elizabeth Wesley. She says, very interesting presentation, and I appreciated the very understanding and compassionate approach. Can you please explain how you handled the sites that never offered specific methods, for example, IUDs? Did you just take the IUDs out of the assessment for them, or did you proceed with the expectation that all centers should be supplying all 6 methods?
Yes, thank you for that question. Yes, we did still include them in all of the analysis, because these health centers are supposed to give all of these 6 family planning methods. Also through another project that ICRH-Mozambique is carrying out, we know that these healthcare providers have been trained in the last year to insert IUDs and implants. So yeah, to put it a bit, to say they were supposed to offer these family planning methods, but it's, so we included them. And I realized that if you haven't inserted IUDs, or if the demand is simply so low that you don't have the opportunity, then you might think, yeah, well, why would I need to have IUDs in stock? But this is how it starts, of course. If you don't have it in stock, you can't offer it when somebody will ask it. So they were supposed to have it in stock and supposed to be able to offer it to their patients, so that's why we included them all.
Great, thank you. Ibrahim Adebayo is wondering, he thanks you for your presentation, and he's wondering how sustainable is this supply side intervention in this setting?
Well, that's a good question also. What we find very positive about this project is, even though we see that the incentives in Group 2 were very motivating, we get almost the same results for Group 1 without incentives, and we even get good results for Group 3. So it's simply supervising and supportive monitoring. You can already get very good results. So so that makes it not too difficult to make the project sustainable. But of course, it's always choosing. They already have shortage of staff, so it's very difficult for the Ministry of Health to organize a team that would do this for all health centers in Mozambique. But I think the idea that with short visits and good supervision you can get far, then maybe you could train the head of the facility to have a more supportive approach for the health staff so that they can take over that job of what our field workers have been doing in the last 10 months.
Great, thanks. And one more question from Kevin Pills. Could you clarify how the incentive provided in Group 2 was linked to the points/credits earned? Could you talk more about if this incentive really increased motivation? So, well, I guess you kind of already just mentioned this, more than the interventions in Group 1 and what the evidence is for that. So you just touched upon that, but if you want to elaborate.
Yeah, of course. Well, so to explain a bit more how they were linked, so the healthcare providers in these 5 health centers were explained that with these credits that they earned, they could kind of change them for materials, for small furniture or medical equipment. So you could kind of see, or they could kind of see each credit in terms of a monetary value. So we had made a list that told them, for example, to buy a chair you need, I don't remember by heart, but to buy a chair you need 2 credits, to buy a cupboard you need 3 credits. So they had a list from which they could pick, and so they could actually save up their credits if they wanted to buy bigger and more expensive things, or they could change their credits every 3 months, I think, for smaller things if they had enough already. So they kind of got a list to pick out that said that how many credits were linked with each of the things they could choose of.
Okay, that's all the questions we've received so far. Thank you so much for those helpful answers, Helene. Does anybody else have any other questions? I'll give it just one more second. And if not, you can certainly reach out to Helene. I think we'll pass along a recording of this webinar, and her contact information will be included in there. And you can also reach out to any of us at the Reproductive Health Supplies Coalition if you have any other questions. If not, you should expect a recording to be passed around, and you can feel free to disseminate to anybody you think might be interested in this really excellent project. And Helene, if you want to close out, I'll just say thank you again so much to you and your team and everybody in Mozambique and at University of Ghent for all of their hard work.
Thank you, Sophia, and thank you one more time to give us this opportunity to work on this project, and we really hope that in the future we can further explore the link of motivation and stockouts and how to reduce stockouts. Thank you.
Great. Okay, thanks everybody. Thanks so much for joining us today. Have a great day. Bye-bye.
Bye.